Everyone. Today we are going to talk about aging and periodontium. Contents: Introduction to aging, general effects of aging on periodontium. That is, we'll be seeing in gingival epithelium, gingival connective tissue, periodontal ligament, cementum, alveolar bone, bacterial plaque, immune response, and also systemic diseases and periodontal health. And conclusion. Introduction: The process of becoming older, a process that is genetically determined and environmentally modulated. It includes the complex interaction of biologic, psychologic, and sociologic process over time. Thus, in contrast to the chronological milestones which mark life stages in the developed world, old age in many developing countries is seen to begin at the point when active contribution is no longer possible. The geriatric population has been growing fast over the last decades all over the world, changing the demographics. Changes in biochemical and physiological processes occur with aging in all body tissues, including the periodontium. Human aging induces histophysiological and clinical alterations in oral tissue. These alterations must be understood to differentiate pathological condition from the altered physiology of oral tissues resulting from aging. General effects of aging on different tissues. External tissues such as hair, with age it becomes brittle, less abundant, and gray in color. Skin, it becomes dehydrated, there is decreased elasticity, and it is thermosensitive. Eyes, it has diminished vision or anophthalmos. Nose, it has diminished sense of smell. Secretory glands, there is a decrease in the epithelial activity of these glands. Renal, there is decreased renal blood flow, leading to water retention, difficulty in removing waste product. Vascular, rise in systolic blood pressure. GIT, it is constipation and gas accumulation due to hypotonic musculature. Gonads, there is decrease of hormones such as estrogen and androgen secretion. In liver, there is decrease in the lymphatic function, and in pancreas, there is decrease in the function, which can lead to diabetes. Now, lip posture, there is drooling or angulochelosis. Muscles of mastication, efficacy of mastications decreases. Tongue, there is alteration in the speech, dysphagia, traumatic bite injury. Swallowing, dysphagia, alteration, motor function. Taste, there is loss of taste or decreased sensation of taste. Now, age-dependent changes in periodontal tissue. The tissue that supports the teeth are called the periodontia, which consist of gingiva, periodontal ligament, cementum, and alveolar bone. Anatomical and functional changes in periodontal tissue have been reported as being associated with the aging process. Changes within gingival epithelium. Thinning of the epithelium and diminished keratinization is seen. Increased epithelium permeability to pathogens. Decreased resistance to functional trauma. Conflicting results have been reported regarding the shape of the retipex. A flattening of retipex and an increase in the height of the epithelial ridges associated with aging were both demonstrated. Gingival sample obtained from a 25-year-old. Okay, this is this. And there is normal aspect of epithelial layers, dermal papillae, and connective tissue without signs of proliferation. And this is the gingival sample obtained from a 66-year-old subject. Thickening of the epithelium due to acanthosis. In morphological 3D study of the epithelium connective tissue interface, connective tissue ridges were observed to be more prevalent in young individual, whereas connective tissue papillae were predominant in old individual. The change from ridges to papilla involves the formation of epithelial cross ridges with advanced age. Number of cellular elements decreases as age increases. The fibroblasts are the main cells in the synthesis of periodontal connective tissue. In vivo and in vitro studies have shown functional and structural alteration in the fibroblasts associated with aging. Gingival fibroblasts may be constantly affected by oral bacteria and their products such as lipopolysaccharides, which are present in their cell walls. The lipopolysaccharides induces gingival fibroblasts to release some inflammatory cytokinins such as prostaglandin E2, interleukin 1, and plasminogen activator 6 or 14. The influence of these inflammatory mediators on both gingival fibroblast and periodontal ligament fibroblast might account for the severity of the periodontal disease. The effect of aging on a location of junctional epithelium has been the subject of such speculation. The apical migration of the junctional epithelium with consequent gingival recession has been discussed. Although such migration is associated with aging, the loss of insertion caused by aging alone may not seem to have clinical significance. Gingival recession progression may occur due to several factors such as passive eruption caused by physiological wear of the teeth, a consequence of anatomically thin tissue, and toothbrushing trauma. Apparently, gingival recession is not an avoidable physiological process caused by aging, but a cumulative and progressive effect from periodontal disease or trauma over time. See, this is recession here. Changes within the gingival connective tissue, coarser and denser gingival connective tissue. Qualitative and quantitative changes to collagen includes increased rate of conversion of soluble to insoluble collagen, increased mechanical change, and also increased denaturing temperature of the collagen. These results indicate increased collagen stabilization caused by the changes in the macromolecular conformation. There is also reduction in the organic matrix production and in vascularization and an increase in the number of elastic fibers. Now changes in the periodontal ligament. There is decreased number of fibroblasts, decreased number of organic matrix production, decreased in epithelial cell rest, decreased number of collagen fibers, which leads to reduction or loss in tissue elasticity. Then cells of PDL have reduced mitotic activity. The thickness of the periodontal ligament varies and may reduce due to the reduction in the force applied by masticatory muscles along the time in subjects with complete dentition or having dental element with no antagonist. On the other hand, when several elements are missing, there might be an overload on the existing remaining teeth with consequent periodontal thickening. Changes within the cementum is there is increase in cemental width, which is a common finding. Increase may be 5 to 10 times with increasing age. Increase in width is greater apically and lingually. Deposition takes place mainly in apical region to compensate for the physiological wear of the teeth. See here. Deposition in the apical region. Changes in the alveolar bone. Reduction of bone mass. More irregular periodontal surface of the bone. Less regular insertion of collagen fiber. Increased bone resorption. The reduction in bone formation might be due to the decrease in osteoblast proliferating precursors or to decreased synthesis and secretion of essential bone matrix protein. The extracellular matrix surrounding osteoblast has been shown to play an important role in bone metabolism. A possible dysfunction of this matrix might occur concomitantly with the aging process. Oxygen-free radicals have been reported to cause cellular damage and consequently contribute to aging process. In an in vitro study, oxygen radical treated fibronectin was found to inhibit bone nodule formation by osteoblasts when compared to the fibronectin. This finding suggested that intact fibronectin plays an important role in osteoblastic activity. Fibronectin damaged by oxygen radical during the aging process might be related to less bone formation. Although age is a risk factor for the reduction of bone mass in osteoporosis, it is not a causative and therefore distinguished from a physiologic aging process. Now, immune response. Age has been recognized as having much less effect in altering the host response. Difference between younger and older individual can be demonstrated for T and B cells, cytokines, and natural killer cells, but not polymorphonuclear cells and macrophages activity. MacArthur concludes that measurement of indicators of immune and inflammatory competency suggested that within the parameters tested, there was no evidence for age-related changes in host defenses correlating with periodontitis in an elderly group of individuals with and without disease. Nutritional effect on immune. Vitamin A increased function is bacterial adhesion and decreased function is salivary antimicrobial properties. Immunoglobulin and lymphocytic production decreased. In vitamin E, there is decreased antibody synthesis, response of lymphocytes, and phagocytic actions. For vitamin C, phagocytic action of neutrophils and macrophages is decreased, and antibody response is also decreased. If zinc is not present sufficiently, antibody response is decreased, fibrocytic function of macrophages is also decreased. Then for riboflavin, vitamin B6, pantothenic acid, antibody synthesis, cytotoxic T cell toxicity, and lymphocytic response is decreased. For folic acid and vitamin B12, cytotoxic T cell toxicity, lymphocyte production, phagocytic function of neutrophil is decreased. Iron, there is lymphocyte proliferation, neutrophil cytotoxic activity, and antibody response is decreased. Tooth periodontium relationship. Loss of tooth substance, such as due to attrition. Degree of attrition is influenced by musculature, consistency of food, tooth hardness, occupational factors, habits such as bruxism, continuous tooth eruption, then gingival recession also. Then bacterial plaque, dentogingival plaque accumulation increases with increase in age, with increase in hard tissue surface area resulting from gingival recession. The surface characteristic of the exposed root surface has a substrate for plaque formation. For subgingival plaque, increased number of enteric rods and pseudomonas in older adults. Periodontal pathogens, specifically including an increased role for T. gingivalis and decreased role for aggregator actinomycete comitans. Association between periodontium and systemic diseases. Infectious diseases such as periodontitis cause inflammation and contribute to level of overall infection and inflammation in the body and may trigger the beginning and or the progression of other diseases such as diabetes and atherosclerosis. There are two mechanisms through which infection and inflammation apparently located in periodontal pockets may harm general health. The passage of periodontal pathogens and their product into the circulation, which is bacteremia, and the passage of locally produced inflammatory mediators into circulation. Now, diabetes mellitus, food consumption, breakdown of carbohydrates in the GIT tract, and absorption of simple sugar into the bloodstream. Increased blood sugar level, secretion of insulin from B cells in the pancreas, This is type 1 destroys B. In type 1 diabetes, these B cells are destroyed, and insulin binds to target cell receptor and allows entry of glucose into the cell used for cellular. In type 2, causes insulin resistance at receptor and post receptors level, thus therefore decreased blood glucose level. It is suggested that the potential interaction between diabetes and periodontitis seem to enhance the morbidity of these two diseases. The chronic hyperglycemic condition of diabetes is associated with damage, dysfunction, or failure of various organs and tissue, including the periodontium. It is due to the increased risk for infection in patients with diabetes, impairment of the synthesis of collagen and aminoglycans by gingival fibroblasts, and increased clavicular fluid collagenollytic activity, altered wound healing. It has been demonstrated by a meta-analysis study that patients with type 1 and type 2 diabetes has worse oral hygiene and higher severity of gingival and periodontal disease compared to non-diabetic subjects. A multivariate risk analysis showed that the subject with type 2 diabetes has approximately threefold increased odds of having periodontitis compared with subjects without diabetes after adjusting for confounding variables including age, sex, and oral hygiene measures. Now, coronary heart disease, periodontal, and cardiovascular diseases are common inflammatory condition in the human population, atherosclerosis being the major component of the latter. Luisi et al. Did a study on association between periodontal disease and coronary heart disease. They found that in patients with periodontal diseases, there are 1.84 times more coronary heart disease. Role of subgingival plaque. Subgingival plaque flora. There is increased access to flora compared to supragingival plaque via ulcerated epithelial lining of the pocket and underlying connective tissue, which on a side antibacterial potential in tissues is destroyed, due to which, and also cellular debris leads to systemic circulation. Then there is alteration in serum components of the clotting mechanisms, and which leads to elevated levels of fibrinogens and risk of future coronary heart diseases. A meta-analysis study indicated that individuals with periodontitis had 1.14 times higher risk of developing coronary heart diseases. The more severe the periodontal disease, the easier the periodontal pathogen could enter the circulation, reaching the blood vessels and atherosclerosis vessel. Another linkage between periodontal disease and coronary heart disease is the level of C-reactive protein, which is an acute phase reactant in response to infection or trauma, and its high sustained level was associated with advanced periodontitis. Ridgerd et al. Demonstrated that C-reactive protein levels predict the risk of coronary level events. Now, periodontal treatment planning in older individuals. Goal of periodontal treatment is to preserve function and prevent the progression of inflammatory disease. Factors must be considered in treatment planning, such as patient, medical and health status, medications, lifestyle behavior, ability to perform oral hygiene procedures, ability to tolerate treatment, amount of remaining periodontal support, tooth type, operator side, decrease the length of surgical time, maintain open communication, minimize trauma, recalculate medication doses, schedule morning appointment. Now, non-surgical approach would be the first treatment of child. Surgical approach depends on nature and extent of disease. Palliative supportive periodontal care. Patients who are not comply with the treatment have poor oral hygiene, medically or mentally compromised or functionally impaired. Now, xerostomia, fluoride rinses and dentifrices, reduce consumption of alcohol, tobacco, spicy and acidic food. Then frequent water intake, artificial salivary substitute. For burning mouth, salivary substitutes, diphenhydramine, choline, lidocaine, mouthwash can be prescribed. Conclusion, aging dental patients have particular oral and general health condition that dentists should be familiar with detecting, consulting, and treating. Medical diseases and conditions that occur more often with age may require modification to periodontal preventive tools as well as planning and treatment phases of the periodontal plan.